Hello everyone. Today we will discuss about ataxia. Most commonly when we are taking a case of ataxia in nervous system, there are a few things which we have to remember and we have to follow during our history taking and also examination. First of all, ataxia is ataxia, that is there is loss of the order. Taxis means order. So there will be loss of order, that is called as ataxia. It can be imbalance of the gait or limbs or speech, and mainly majority of the times ataxia is because of cerebellar dysfunction. Second common cause is sensory ataxia, then comes other possible reasons. And whenever there is gait ataxia, it means that there will be sense of insecurity during the walk, mainly during the turnings and all. So that is a brief introduction about ataxia. So whenever we get the complaint of ataxia, we have to first decide whether it is because of the cerebellum or is it sensory ataxia because of posterior column involvement or other reasons like frontal lobe lesions or some vestibular lesions. So for that, always remember, whenever a person starts walking, so it will involve many components. So we have to assess the ataxia in that pattern itself. For example, we have to assess the posture of the trunk first. So mainly we can differentiate these three based on the components which are involved in initiation of the gait and the gait proper and few other things which we will deal now. For example, first we have mentioned about the posture of the trunk. So posture of the trunk, if it is cerebellar related, it can be normal. If it is sensory related, posture will be normally upright maintained. But if it is because of frontal lobe lesions, we know that there will be stooped posture. So stooped posture goes in favor of frontal lobe lesions. So once the posture is done, then you just assess the stance, that is how the person or the patient is standing. So mainly in the stance, if he prefers to be in wide-based stance, that will go in favor of cerebellar dysfunction, whereas the stance will not get affected much in case of sensory ataxia. And in some frontal lobe lesions, stance, usually the person will try to keep the feet together. Then once the person is able to stand, then we have to ask him to initiate the gait. So how does it help in differentiation? Initiation of gait might be normal or slightly slow in case of cerebellar and sensory dysfunction, but it is very slow in case of frontal lobe lesions. So we usually call it as abulia. That is, there will be resistance or hesitation to initiate the like motor actions. Here, particularly the gait. Then once he started to move, we have to observe for the steps. How is he keeping the steps? So here in cerebellar dysfunction, there will be lurching or wide-based steps will be there. Whereas in sensory ataxia, it will be high stepping kind of thing will be there. Whereas in frontal lobe lesions, mainly like Parkinsonian disease, there will be, the steps will be short shuffling steps. So this will help in again differentiation. Then observe for the speed of walk, speed of the gait. So usually speed will be slightly normal or slightly lower in case of these two because of the fear of fall. Whereas it will be too slow in case of frontal lobe lesions. So that is done. Then once he starts walking, once he reaches some distance, ask him to turn around and return back. So that turning itself will help in again differentiation. For example, there will be reeling towards one side, which we can see in majority of the cerebellar lesions, that is related to turning. Whereas sensory ataxia, there will not be much difficulty in turning around. Whereas in frontal lobe lesions, they will turn in N block, like the whole body will turn at a time. So that we call it as N block turns. And falls, cerebellum lesions, we might observe reeling or like swaying too much, but usually they will not fall. Whereas falls are very, very common in case of frontal lobe lesions. So that is about turning and falls. Then once the individual reaches back at the point of initiation, then we have to assess for Romberg's test. Here one thing very important related to Romberg's test is, if the person is preferring to be in wide-based stance and his gait is wide-based, that itself indicates that he is unable to stand with both feet together. So there is no chance of testing the Romberg's test, because when the person is not able to stand with feet closed, then there is no chance of further proceeding with closure of the eyes. So this point we have to remember, especially when we are dealing with cerebellar ataxia. We observe that the stance or the gait will be wide based. Then you should not mention that Romberg's test is negative or Romberg's test is something like that. You just mention Romberg's test could not be assessed. That will be the preferred sentences for the students. Then once Romberg's test is done, so what is the importance of Romberg's test? Suppose the patient is standing normally, and then we ask him to stand with both feet closer. So if there is cerebellar dysfunction, he will not be able to stand with feet closer. But if the cerebellum is normal, he will stand with feet closer. Then we have to ask him to close the eyes. So once he closes eyes, if he feels swaying or if there is any imbalance, that will suggest posterior column involvement, that is sensory ataxia. Then we can consider Romberg's test as positive. So after that, we have to ask that individual to perform tandem walk. Again here, remember one thing, if during the initial assessment, if he was preferring to be in wide-based gait or wide-based stance, there is no chance of him to perform tandem walk. These are all the indirect inferences which we have to consider. So again here, tandem walk, if he is not able to perform, that itself indicates cerebellar dysfunction, whereas in sensory and frontal lobe lesions, they will be able to perform tandem walking. So these are the headings in which we have to follow the pattern, so that we will be able to differentiate whether it is cerebellar or sensory or something else, mainly frontal lobe dysfunction when it comes to ataxia. And as I told in the beginning, most common reason for ataxia is cerebellar dysfunction. So we will deal it in some detail now. Now once we are in favor of cerebellar dysfunction, what we have to do is first consider the age of the patient. So mainly in young adults and older adults, which will be dealt in the medicine most commonly. So considering the adults, you divide it according to the temporal evolution, that is based on the duration of the symptoms. Suppose whether the duration is acute or subacute, or it is a long standing ataxia, that is chronic. So once you divide it into acute, subacute and chronic, again you divide it into two subdivisions, whether it is symmetric presentation or asymmetric. Even if it is subacute duration, whether it is symmetric or asymmetric. Even in chronic, the same thing, whether it is symmetrical ataxia, long-lasting ataxia, or it is asymmetrical long-lasting ataxia. So this is how we will divide: acute, symmetric, asymmetric, subacute, symmetric, asymmetric. Then we will be easily able to list out the causes according to this. So first is, we are discussing about young adults or older adults. So for example, a 40 or 50-year-old adult presenting with sudden onset, short span of ataxia, that is of few days duration, and it is symmetrical, like he is having imbalance on either side. So what might be the cause? Most commonly, it will be because of the cerebellitis. That is, we have to ask him regarding mainly the history of fever or any vaccination, something like that. Or there might be chances of toxicity. There are many drugs or toxins, heavy metals, which can lead to sudden onset, acute, symmetrical ataxia. Most commonly in this one is alcohol toxicity or anticonvulsant medication like phenytoin toxicity. So we are discussing about the toxicity, not just the intake of alcohol and phenytoin. Then comes another example for a scenario, individual, for example, a 50-year-old man presenting with 5 days history of ataxia, but it is asymmetric, like he will feel swaying more towards the left side or right side, like that. So it is asymmetric. So first thing, especially in the older adults, we have to consider is vascular event, that is nothing but stroke. Or if the individual is an young adult and if there are any previous similar episodes, consider multiple sclerosis. Or if there is any history of fever with chills and all, or any signs of infection, consider cerebellar abscess. So these will lead to asymmetrical sudden onset ataxia. Suppose the duration of the symptoms is for few weeks to months, few weeks to months, and it is symmetric. For example, symmetrically he is having the ataxia for few weeks to months. Then there will be possibility of some nutritional deficiencies. For example, B1 thiamine deficiency or vitamin B12 deficiency, or some metabolic dysfunctions like hypothyroidism. HIV infection, some autoimmune disorders, or there might be possibility of paraneoplastic syndromes, which will manifest as ataxia, that is symmetrical. Coming to the asymmetric subacute duration of ataxia, consider posterior fossa tumors. So in this one, there will be asymmetric ataxia, which will be lasting for a few weeks to months. In this one, very important thing is always look for the fundoscope. So there might be evidence of raised ICT. Coming to the long-lasting symptom of ataxia, which will last for years together, that is chronic. If it is symmetric, then consider any hereditary abnormalities. Otherwise, long intake of the alcohol can lead to like Vermean degeneration or cerebellar degeneration, which will present as symmetric ataxia. One more reason might be some infections, especially HIV, and in olden days it used to be syphilis also. So few infections can lead to long-lasting symmetrical ataxia. Coming to chronic asymmetric ataxia, there might be some tumors, especially again posterior fossa tumors. So asymmetric subacute to chronic duration, there might be chances of posterior fossa tumors. We have to remember this. Or there will be congenital anomalies which are causing asymmetric chronic ataxia. So this chart has to be there as question number 2. Question number 1 we have already discussed, whether it is first to differentiate whether it is cerebellar, sensory, or due to some other reasons. Second one is to divide it into like this pattern so that we will get some possibilities as the cause for ataxia. And same thing will be followed even in very young childhood onset ataxia, but mainly like there will be congenital anomalies we have to focus on, and hereditary abnormalities, and some tumors, posterior fossa tumors, and other stroke like thing will be rare in childhood onset ataxia. So consider these 2-3 possibilities and follow the same pattern even in childhood onset ataxia. This is about second thing. So the third question in approach to ataxia will be any associated symptoms we have to assess. For example, ataxia plus any features of infection. So here we have to consider again the possibilities. So what infections can lead to ataxia? Remember few things like especially HIV, CJD, Whipple's disease, or some viruses, viral infections. Then any associated history of seizures. So this is important especially in case of some mitochondrial disorders and SCA, spinocerebellar ataxia. Then assess for any features of neuropathy, like any sensory abnormalities. Why is it important? Because ataxia will be associated with neuropathy in case of Friedreich's ataxia or Fragile X syndrome, or vitamin E deficiency, and SCA again, spinocerebellar ataxia. Similarly, we have to assess is there any feature of dementia like cognitive dysfunction. Why is it important? Because again it is seen in some mitochondrial disorders and SCA. Then we have to ask for the family history, because sometimes ataxia will be hereditary. In that, mainly Friedreich's ataxia, ataxia telangiectasia, or episodic ataxia we'll say. So many things will come, and SCA also. So these are few possibilities in case of family history. And we have to assess for toxin exposure, especially mercury, lead, or some solvents, etc. So mainly occupation related thing will help in this one. And any other symptoms like headache, blurring of vision, seizures, etc. related to neuro, if they are present, always consider SCA. And if the individual is very young, consider mitochondrial disorders causing ataxia. So this one will help again in the like finding out the causes, probable cause for ataxia. So this should be the third question. Question number 4 in ataxia is about head to toe examination. So it is not just about pallor, icterus, cyanosis, clubbing, edema and all. When we are dealing with ataxia, there are few things, as we discussed some causes recently. So we have to assess for short stature. So where do we observe short stature in relation to ataxia? It will suggest mitochondrial diseases. Then what about hair loss? Hair loss will be seen in hypothyroidism. So that might be the clue. for the cause of ataxia. And then look for the eyes. In eyes, especially conjunctival telangiectasias, that will be seen in ataxia telangiectasia. And look for any tendon xanthomas over the limbs. So that is cerebellar xanthomatosis might be the reason for his symptoms. And then observe for any deformities in the spine and foot, like long-lasting hereditary neuropathies or diseases can lead to deformities. So in this case, related to ataxia, consider Friedreich's ataxia or any hereditary ataxias. So at least these things have to be observed when we are commenting about head-to-toe examination in ataxia case. This is about question number 4. So next important question related to ataxia is localization of the lesion in the cerebellum. So we have to know few things related to the anatomy of the cerebellum. Mainly, we will make it very easier. As we know, this is the flocculonodular lobe. Flocculonodular lobe. So we call it as archicerebellum. This is the oldest in the evolution. So it lies at the center and posterior part. So this will deal mainly with central, like axial stability. So mainly it will deal with truncal balance, like if there is any truncal ataxia, person is not able to even sit. So that is truncal ataxia, that might be because of the dysfunction of the flocculonodular lobe. And nystagmus, if it is present, that will indicate again loss of central balance. So this is about part 1. Second important part is, as we know, it is about vermis. So the central part is vermis. And paravermian region, we call it as paleo-cerebellum. So this is the second one to develop in the evolution. So after the central stability, in the evolution, there was development of the stability of the girdles, limb girdles. So this is mainly dysfunctional, and if it is dysfunctional, it will present as gait ataxia. So it was truncal ataxia, and this is gait ataxia. Then this was handling nystagmus. Here, if any dysfunction is there, we will see corrective saccades. Saccadic movements will be seen, and this is also responsible for dysarthria, sometimes seen in cerebellar lesions, that is scanning or staccato type of speech. But for speech handling, like left side of the hemisphere of the cerebellum is also involved. So either of two, if it is getting lesion or dysfunctional, we will be able to observe dysarthria. So this is about part 2. Then third one is about cerebellar hemispheres. So these are the cerebellar hemispheres on either side. Hemispheres. This is called as neocerebellum, newest. So this is involved in the coordination of the limbs, like movement coordination of limbs. So any dysfunction in this part will lead to limb ataxia, and it will present as there are few tests which we will do in the cerebellar examination, like finger nose test, or there will be dysmetria, dysleidocokinesia, and they will not be able to do heel shin test. So all those are related with the coordination of the limbs. So that will be affected. And as it is a newer feature, so any cognitive dysfunction, if associated with ataxia, we have to consider lesion in the lateral hemispheres, cognitive dysfunction. And some important things are, if the outflow tract, fourth one is, if there is lesion in the cerebellar outflow tracts, so we will be able to see square wave jerks. So these are few things which we have to remember when it comes to localization of cerebellar lesions. So the final question related to ataxia will be, why not it is sensory ataxia? So you should be able to justify with some explanations. For example, in the history, there is no wash basin phenomena, or any sensory dysfunctions like abnormal sensation or loss of sensations, sensory dysfunction. No band-like sensation, especially band-like sensation. And when we are assessing the case, there will be Romberg's positive, Romberg's test positive, and some sensory abnormalities. And the gait will not be wide based, it will be usually high stepping gait. So gait is also important, it will help. And other important things are, there will not be no involvement of speech, no dysarthria or ocular movement abnormalities like nystagmus or saccadic intrusions, square wave jerks, etc. That will not be seen in sensory ataxia. So this much should be your justification to say it is not sensory ataxia. So this is the minimum overall approach when we consider a case of ataxia, that is imbalance. Hope it will be helpful for you. Share it with your friends and do revise it. Thank you so much.